Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for the Canadian Partnership Against Cancer's National Synoptic Pathology Project. And on behalf of CPAC and the Canadian Association of Pathologists, I'd like to welcome everyone to today's educational session on the new CAP checklist for prostate cancer with Dr. Peter Humphrey. Before I introduce Dr. Humphrey and we get underway formally, I'd like to go through a few housekeeping items first. Today's presentation will be approximately 90 minutes in length and will include about 60 minutes of presentation time followed by about 30 minutes of question and answers. The session is being recorded and will be made available to all participants via email once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon the electronic completion and submission of a pre-circulated evaluation form to the following email address, pathology@partnershipagainstcancer.ca. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of the teleconference, please call the WebEx support line at 1-866-229-3239. To pose a question for our speaker, I would ask you to use the chat section of the WebEx screen. For instructions on how to use that WebEx chat window, please refer to the documentation that has been previously distributed. In order to avoid question collisions and confusion, I will pose the submitted questions to Dr. Humphrey on your behalf as long as time permits and in the order that they appear on the screen. Questions can be typed in at any time during the 90-minute teleconference. In the chat window, I would ask you to include your institutional name, the name of the person posing the question, and finally your question. It is now my pleasure to introduce Dr. Peter Humphrey, a longtime colleague, collaborator, and personal friend. Dr. Humphrey is the Landison Professor of Pathology and Immunology at Washington University School of Medicine. He's the Chief of Anatomic and Molecular Pathology and Professor of Surgery and Urologic Surgery in the Department of Pathology and Immunology and Surgery at Washington University School of Medicine. He's an attending pathologist at Barnes Jewish Hospital and the Children's Hospital of St. Louis as well. Dr. Humphrey is a graduate of the University of Kansas and completed his residency program at the Department of Pathology at Duke University in 1988, and since then has gone from Duke University to Washington University School of Medicine. He is a author of more than 200 papers, many of which relate to prostate cancer, and as well as published 5 textbooks, including the now famous ASCP textbook on the pathology of the prostate gland. He is also a senior author of the protocol for handling prostate cancer, published by the in Archives of Pathology Lab Medicine in October for the College of American Pathologists. Ladies and gentlemen, I present Dr. Peter Humphrey.
Thank you so much, John, and it's a real pleasure to be with you all today via the web. We apologize for the technical difficulties, and we do have a full program here, so we should probably go ahead and get started. So the title of today's presentation is, as you see on the first slide, it's the College of American Pathologists, or CAP protocol, for the examination of specimens from patients with carcinoma of the prostate gland. I must say up front that I have no financial interests, unfortunately, to disclose in this matter. So the overall objective of today's session will be to provide an overview of the newly released and published 2009 CAP Cancer Protocol for Prostate Cancer. So when we talk about prostate cancer, we'll specifically, again, be focusing on carcinomas of the prostate exclusively. And just by way of background, there have been interactions between the Canadian Association of Pathologists and the CAP, and the Canadian Association has now formally endorsed the CAP protocols as part of a content standard for reporting of cancer specimens, and this was done just very recently in July of 2009. So what is the goal of the CAP protocols? These actually have been around for quite some time and now have been updated on a pretty regular basis. Their goal for these specimens from patients with cancer is, in their words, to assist pathologists in providing clinically useful and relevant information when reporting results of histopathologic examination of surgical resections. And the essential elements are included in publications and on the web in the surgical pathology case summary or checklist. So when we refer to checklists, we'll be talking about these case summaries that are embedded within the protocols. So it turns out that in the United States, these checklist elements are actually a very important part of the review of cancer centers and cancer programs around the nation. And in fact, the checklist elements themselves are mandated for use by cancer centers and cancer programs. And this review occurs by sponsorship of the Commission of Cancer of the American College of Surgeons. However, there is freedom in the reporting of these elements, and so the manner in which, and these again are the exact words from the CAP, the manner in which these elements are reported is really up to the individual pathologist and taking into account individual and local customs at one's hospital or clinic, and taking into account also the interactions one has with one's clinical colleagues, institutional policies, and then preferences as far as individual practice and reporting. So if you wish to review the entire publication, here is the title of that publication and the authors, and Dr. Shrigley was the lead author in this publication, and there were many contributions by urologic pathologists here in the U.S. and around the world. And that's an important change for this updated CAP protocol. And we also have as co-authors clinicians, so they provided their input as to clinical impact of our reporting. So this really was a multidisciplinary and broad approach to crafting of these important protocols. And the reference is at the bottom of your screen, as you can see it in the archives of Pathology and Laboratory Medicine, just published in the October issue of 2009. And we'll basically be progressing through the protocol as it's published in that form and in that journal. So why is the timing so important now for this publication? And it turns out that the new 2010 AJCC, American Joint Commission on Cancer, and the UICC, International Union Against Cancer, TNM system was just released. And it turns out that the CAP, via the Cancer Committee, worked very closely with the AJCC in the development of this new TNM system, and the CAP specifically targeted the release of the new cancer protocols to coincide with the release of the new TNM publication, which has been out now for just the 7th edition of the AJCC Cancer Staging Manual has just now been published and out for only a few months. So that was important coordination and timing. So what are some of the updates to the prostatic carcinoma CAP protocol? Well, first of all, new TNM staging has been incorporated into the protocol. So it's very up to date in that regard. There has been an attempt to uniformly across all the cancer protocols, and this was applied to the prostatic carcinoma protocol for streamlined formatting that made for easier readability and also in checking off of the various elements. And for the first time, we also have images published, several of which are from the AJCC Cancer Staging Atlas. And those are some nice illustrations, and one that we'll see later on that Dr. Shrigley and I created. And we've also attempted to incorporate the recommendations from the 2009 ISEP. We'll be referring to that abbreviation throughout the session, which stands for the International Society of Urological Pathology. And this was a meeting in Boston at the International Academy of Pathology just this past year in 2009 in March. And it was a meeting that focused on radical prostatectomy specimens. And this was truly an international gathering with some 116 pathologists representing 23 countries. And so those recommendations have also been incorporated into the CAP protocol. Again, as we noted, there was input into the protocol from international co-authors and clinician co-authors. And I think it's also the update was due because the last protocol was published some 3 years ago, as you can see at the bottom of this slide, published again in Archives 2006. So let's talk about the checklist. So the checklist is basically assembled based upon the type of tissue specimen that is obtained. So for the prostate gland, we basically have 3 major categories, and the first category being needle biopsy, the second one being transurethral resectates from the prostate, or TURs, TURPs are abbreviations that are commonly employed. And also in that same category, nucleation specimens, which refer to prostatectomies, not radical prostatectomies, but rather simple or open or subtotal prostatectomies. Those are all surgical terms too that refer to that type of procedure. And then finally, the radical prostatectomy, which is surgery for prostate cancer, in distinction to the subtotal prostatectomies, which are performed for BPH and are enucleations really only of the transition zone and BPH nodules. And in the published protocol in Archives in 2009, explanatory notes, which go into some detail about the various criteria within the checklists, follow after the checklist, and those explanatory notes then I think provide a window into the thinking behind the requirement for various checklist elements. So now let's focus on the prostate gland and needle biopsy reporting. There are 4 major required elements, and we'll go through these one by one. The first one that we'll talk about is histologic typing. The second one is histologic grading, and when we talk about grading, it'll be exclusively Gleason grading, which is now the international accepted standard, and that's true in the new AJCC Cancer Staging Manual as well. And what's become increasingly important is the quantitation of amount of cancer in needle biopsy tissue, and this is being used clinically and is very important for us to provide in our reports. And then also, when we do see it, periprostatic local invasion into fat and seminal vesicle tissues, when it is possible to identify those particular features. Those are admittedly uncommon in needle core tissue. So the first 3, no matter what, one should definitely provide, and then the 4th, when present. So a required element for the needle biopsy is histologic typing, and it's pretty simple, really. Under histologic type, one can specify adenocarcinoma of usual acinar or conventional type. And in fact, in most of our practices, when we diagnose adenocarcinoma, we don't specify that it's acinar. It's usually left as assumed that it's acinar. And as you can see on the right-hand side, this is a good example of a typical usual acinar adenocarcinoma, and a common grade that's applied in this PSA era, and that is a Gleason grade of 3 + 3 = score of 6. And you can see how the small glands, and prostate cancer is a prototypic small gland malignancy. The small glands are infiltrating in and amongst the more benign glands, which are more complex and pale. And then you can see at high power the nuclear atypia we wish we had in every case, that is the large prominent macronucleoli and the gland-forming ability of these particular malignant cells. So in this case, it would be a relatively simple assignment of just adenocarcinoma, parentheses acinar. So as far as histologic typing, the CAP protocol has a classification scheme based upon the 2000 Armed Forces Institute of Pathology Prostate Fascicle, and we see that now in this slide. And this really follows pretty closely to the World Health Organization Blue Book classification. And so if one did not diagnose adenocarcinoma of usual type, which is about 95% of all of our cases, then one should specify the other histologic types of carcinoma as we see in this list, including, and now we'll list them, prostatic duct adenocarcinoma, mucinous or colloid adenocarcinoma, signet ring cell carcinoma, adenosquamous carcinoma, small cell carcinoma, sarcomatoid carcinoma, and then an undifferentiated carcinoma. One should note that the protocol does not specifically apply to certain histologic types, and that includes squamous cell and basal cell carcinomas. These are all primary in the prostate, primary urothelial carcinoma of the prostate, and the very rare lymphoepithelioma-like carcinoma in the prostate. And this just shows an example of one of these unusual histologic variants of prostatic carcinoma, and this is prostatic ductal carcinoma. And this was discussed in a very nice series from Johns Hopkins. That reference is listed at the bottom of your slide. And you can see at the tip of one core on the left, needle core, you have high columnar cells, and that's going to be an important definition of ductal carcinoma that will be presented in the latest AFIP FAST-O, which should come out this coming year. So high columnar cells, gland forming, and you can see on the right it has almost somewhat of an enteric appearance. And a cribriform growth configuration is very common. You can see that here on the left, and papillary growth is probably the most characteristic. But you can also get solid growth, comedo growth, and very uncommonly small gland growth. You can see a suggestion of that on the right-hand side. Anyway, just an example of the variants of prostatic carcinoma that do apply within the CAP protocols and which should be diagnosed. So the next required element in needle biopsy tissue is histologic Gleason's grade. And basically here are the checklist elements. We'll talk about when Gleason grade assignment is not applicable or cannot be determined. Basically, one should assign a Gleason grade to all adenocarcinomas where there is not treatment effect. And that includes, as we shall see, very tiny, small adenocarcinomas of the prostate. So even if it's just a few glands and you're certain that it's malignant, then one should assign a Gleason grade. And then one should assign a predominant pattern in the classical Gleason style. One should assign a primary predominant pattern grade 1 to 5, and then a secondary pattern as also 1 to 5. And we'll talk about tertiary patterns in just a second to arrive at a Gleason score. It is really difficult to say that Gleason grading is unimportant because it is so critical in the clinical management of patients with prostate cancer. And in fact, it is important in all of these different avenues. Specifically, it is a powerful, and some would argue the most powerful predictor of outcome for patients with prostate cancer. It can be utilized, as we shall see, with serum PSA, an amount of cancer in the needle core tissue to predict small, potentially harmless prostate cancers, and is used in nomograms and in tables to try to select patients for specific therapies. And that includes both initial primary therapy as well as adjuvant therapies. And can be used as a criterion for enrollment into clinical trials. So really we need to render a Gleason score in all cases of adenocarcinoma where there is no treatment effect. And so this is a minimal carcinoma, yes, very small, but one should still apply the Gleason grading scheme. Here you can see benign glands in the needle core on the left-hand side with some atrophic features lower down in the core, and there's adenocarcinoma that stands out in the middle of the needle core. And you can see that it is possible to recognize two different patterns, even within minimal or limited adenocarcinomas within the prostate. So here, there's a combination of a classical Gleason pattern 3 single separate adenocarcinoma glands right next door to gland fusion representing classical Gleason pattern 4 high-grade adenocarcinoma. So using, although it's close as to which is predominant here, the way to grade this out then would be the predominant Gleason pattern 4 plus the secondary Gleason pattern 3 and arriving at a score or sum of 7. Now, treatment effect can definitely impact the appearance of prostatic carcinoma and can often make the carcinomas appear much higher grade than they actually are. And this is true for both hormonal therapy as well as radiotherapy. And so basically, just uniformly, one should not, with one exception we'll mention in just a second, one should not provide a Gleason grade post-hormonal therapy. And we'll talk about that, we'll show an example of that in TUR chips in just a second. But usually we're not going to see that in needle biopsy tissues. That is, patients treated with hormones and then those patients undergo a subsequent needle biopsy. On the other hand, we're more likely to see this, that is a follow-up needle biopsy after initial diagnosis of adenocarcinoma after radiotherapy. And it's actually okay to provide a Gleason grade post-radiation therapy if the cancer looks very much like it did before therapy. So you can see on the right-hand side, the upper image is of a treated prostate carcinoma and treated with radiotherapy, but this is a radioresistant cancer. So there is no treatment effect. And it's okay to grade that particular case. However, if there is radiotherapy effect, and that's shown here on the bottom in the image on the right-hand side, there is substantial treatment effect on the cancer, and that entails basically nuclear pycnosis, shrinkage, as well as cytoplasmic vacuolization, and basically holes in the tissue, sometimes with absence of nuclei. So this is classical radiotherapy effect, and in those cases, one should not apply a Gleason grade. And so here's the principle of application again of applying in a non-minimal case the most common pattern here, gland fusion, high-grade Gleason pattern 4 plus the secondary pattern, Gleason pattern 3, single and separate glands, shown at higher power on the right, coming up with an overall score of 7. So some other key elements of Gleason grade reporting in needle cores. If there's just one grade, all one does is double that grade to provide the Gleason score. And it's very common that we see only a Gleason pattern of 3, and so one should definitely double that and provide a formal score of 6. Because it is very often the score that will be plugged into nomograms and tables, for example, the Parton tables. And now here's a practice area where there is, I would say, sorry about that, controversy as to how to assign the Gleason grade, and basically many pathologists will assign the Gleason score by container, even if there are multiple cores. Alternatively, and some pathologists do practice this way, one may assign a Gleason score for each core that is positive for cancer. And there can be some one of the challenges I think in assigning the score for each positive core is if there are multiple positive cores in a container. Let's say you get multiple cores submitted for container, and multiple cores are positive, and then let's say if the core is fragment, then it's actually very difficult to ascertain the number of positive cores. And so that's one challenge, but it is an option. This is obviously circumvented if our clinical colleagues submit a single core per container, which is actually, for many reasons, a preferable practice. And that way we can just assign a Gleason score, and our clinical colleagues and physicians will know that Gleason score pertains just to that one core. So, mixed practice, one can choose either way. I know that Dr. Shrigley and I prefer to assign Gleason score by container, irrespective of the number of cores in that container. Now on to tertiary patterns. So this is important to recognize, and that there is a special way of handling tertiary patterns in needle biopsy cases compared to radical prostatectomy cases. So in needle biopsy cases, if there are 3 patterns, you take the most common pattern, the predominant pattern, and then the worst of the remaining 2. So if you've got 3 patterns, and this happens uncommonly in prostate needle cores, probably only about 5% of all needle core cases, but it does happen. So if you have a case where there's patterns 3 plus 4 plus 5 all in the same core, then what one does is take that 3 as the most common pattern, and then 5 because that's the highest of the next two, and you basically give a score of 8. And this approach has been validated as being clinically relevant and important. There was a recent paper in JAMA, actually, just a couple of years ago, where this incorporating the tertiary pattern did predict outcome for patients. So here's another just example of a high-grade case where the grade is doubled, and you can see now there's Gleason pattern 4 throughout the core, masses of fused glands, cribriform glands, and all of this represents 4 plus 4 equals score of 8. And it's important to look for a small tertiary component. So even if there's only a few percent of the cancer cells are Gleason pattern 5, it's important to incorporate that into the score. And in fact, many of the papers in the literature dealing with tertiary patterns use the less than 5% rule as far as identification of that tertiary pattern. So it's also important to know about the CAP and ISUP recommendations for a limited secondary pattern when it's less than 5%. And basically, the important point is that one should always incorporate high-grade disease into your score, no matter how much there is, even if it's only a very tiny fraction of the overall total amount of cancer. So in needle biopsy cases, let's say if there's a minor component that's Gleason pattern 4, but it's only 4%, incorporate that into the score when the vast majority of the case is 3. So a small amount of 4 will make that 6. However, if the secondary pattern is lower grade and the vast amount of cancer is high-grade disease, one should ignore just a very few glands that are low grade and go ahead and report that out as, for example, Gleason score 8, when there is 96% pattern 4 and only a few glands of pattern 3. All this just points to the highly significant nature of high-grade disease. Just as an aside, there has been an evolution in the Gleason grading diagram. So in the past, the classical one, which was drawn by Dr. Gleason himself, is seen on the far left. And what has happened over time, and this has been evidence-based, is that there has been a shift to some patterns to different grade categories. So in 2005, the International Society of Urologic Pathology endorsed the middle diagram, and then most recently in the upcoming AFIP fascicle, the diagram on the far right will be utilized. And what you can see what's happened is that cribriform adenocarcinoma has now moved completely out of lower grade pattern 3 and into higher grade pattern 4. And there's evidence to support this shift. And that's a really important change in our practice, that higher grade, right, so here's the cribriform adenocarcinoma. I hope you all can see my arrow. In the previous Gleason schemes, and now you can see with this most recent scheme, and almost all urologic pathologists would endorse this, that there are single separate glands in pattern 3, whereas now pattern 4 is cribriform adenocarcinoma, as well as fused glands, gland fusion, as well as poorly formed glands, and pattern 5 is sheets of carcinoma cells, single cells, as well as comedonecrosis, comedocarcinoma. So those are some big changes, and actually the single cells aren't that well represented in the old pattern also. So when we write about the Gleason grading in our CAP protocol, what we mean is that one should apply a Gleason grading scheme as you see it illustrated in this most recent diagram on the far right. So this looks complicated. It's actually not so very complicated, but it just speaks to about how one should approach quantitation within needle core tissue, that is the amount of cancer. And definitely, so there are basically three different approaches here based upon how many different parameters one wants to report. So what one should definitely report, no matter what, is the number of cores positive out of the total number of cores. And you can do this by container. And then you have an option of reporting the percentage of cancer in the tissue just by simple visual inspection, and or measuring the total linear millimeters of cancer in the tissue. So I have to say, for our urologists and physicians here, and for consult cases I report all three parameters. So I report the number of cores positive out of the total number of cores, and again, this is by clinician, physician, radiologist-driven, site-specific containers, visual inspection estimate of the percentage of tissue involved by cancer, and you can do this in simple increments of less than 5%, 5%, and then 10, 20, 30%, and so on. It actually doesn't take much time. And then I also provide a measurement of total linear millimeters of cancer, and I often do this just by inking the areas of cancer and then putting a ruler on those areas so that you can get linear millimeters. You can stick a ruler underneath your microscope and measure linear millimeters that way. And for those who really like your melanoma micrometer, you can get that out and measure total linear millimeters. And these are all, as you might imagine, highly interrelated measures of amount of cancer. And all are related to important pathologic and clinical endpoints, and are being used clinically, perhaps most importantly. So here's an example of how the amount of cancer is being used clinically. So this is one of the Catan nomograms, and basically this is a way in which one can predict response to surgery, radical prostatectomy, and determine the chance that the patient is free from progression, that is, an elevated serum PSA after surgery. And the most important preoperative parameters are the PSA level, the number of positive cores, number of negative cores, clinical stage, and then the primary and secondary Gleason patterns. And the way this works is that for each separate parameter, you get a point. You get a point score. So, for example, if the patient has, that's a lot of cores positive, 7 cores positive, you drop down and that gives you 15 points. Well, so you get points for each one of these parameters and sum those to give total points. And once you have your total points, you can then move up, for example, if there were 200 total points, up the curve and find out over time, after surgery, what the chance is. 70% chance, for example, out at 96 months after surgery, 70% chance that the patient would be progression-free. So obviously the more points, the worse the outcome. So just an example of the clinical importance in predicting response to therapy for Gleason grade and positive cores in neobiopsy parameters that are addressed in the CAP protocol. I also want to emphasize in this era for men who are diagnosed with potentially harmless or indolent cancers, we can try to predict those types of cancers using, again, biopsy Gleason grade, serum PSA, and amount of cancer in the cores. And so these are active surveillance protocols. Nice summary in the journal Cancer, just published in 2008. Goes through all the different models that are used. These are some of the most common parameters for enrolling patients, for considering patients for enrollment into an active surveillance program or protocol or follow-up, for example, for individual patients. Active surveillance, another term that's often used, is watchful waiting, although surveillance means that the patient's PSA will be followed closely and rebiopsy will also be performed. Any regard for quantitation, again, percentage of cores that are positive out of total cores important. And it turns out that this is optional. One can report the amount of cancer in those cores that are positive for cancer because it is a parameter here for consideration of active surveillance rather than active therapy such as surgery, that is radical prostatectomy, or radiotherapy. So what are the elements that are not required? Well, actually in this list, when we talked about that, periprostatic fat invasion, you should document it if you see it. It's usually straightforward. Sometimes not so straightforward is identification of seminal vesicle invasion by carcinoma, but one should document that if you see it. And all of the other findings one needn't go out of one's way to document, although it is recommended to report lymphovascular space invasion and perineural invasion if you do see it. Not absolutely required, but can be helpful. But as we just saw in the Caton nomogram and the active surveillance protocol, these parameters, that is lymphovascular space invasion and perineural invasion, are not in those list of criteria used to manage patients or consider a response to therapy. If you see high-grade PIN admixed with cancer, no need to report it, as we'll see in just a few minutes. It is important still in this era to diagnose isolated high-grade PIN when you don't see cancer, but all of this refers to parameters that are not absolutely required, although with cancer, although we would recommend lymphovascular space invasion and perineural invasion reporting. So here's a case showing an example of local invasion into fat, which can be sampled in our prostate needle cores, shown here, adipose tissue. And you can see the adenocarcinoma extending into the plane of the fat, and actually into the fat itself. So this is all basically these glands all here represent extraprostatic extension by carcinoma into periprostatic adipose tissue. One should report it. Patient has technically PT3A disease. Another type of local invasion is into the seminal vesicle, and what we mean by that type of invasion is seminal vesicle wall tissue specifically, and that's PT3B disease. The problem here is that it can be difficult to impossible to tell apart seminal vesicle wall from ejaculatory duct wall. The epithelium, as we can see here on the right, is exactly the same. You have those monstrucellular smudge cells, and sometimes you can have pigment, although it's you can only see a suggestion of it here. But the thickness of the wall is really difficult to determine in these needle core samples. So I'll usually mention diagnosis and adenocarcinoma, see comment, and say that it could represent seminal vesicle wall tissue or ejaculatory duct tissue if I'm not certain, and I'm not certain in this case. And this can be an incidental finding, by the way, or can be a targeted biopsy for the seminal vesicle, although most practicing urologists and radiologists currently don't try to target the seminal vesicle for staging, although occasionally we may see such a biopsy. So perineural invasion, is probably an important biological mechanism for escape of prostatic carcinoma cells outside the prostate. That is, by tracking along perineural sheaths, the carcinoma cells can extend out into periprostatic soft tissue. And it turns out, therefore, that there is this association when we see perineural invasion, as shown here on the right, by carcinoma in needle core tissue. It is associated with pathologic stage, but usually Gleason grade, and the amount of cancer in the needle core trumps that finding, so that it's often not significant in multivariate analyses. And it's really not present in many nomograms or tables to predict response, although there is some data in the radiation oncology literature that it may help predict response to external beam radiotherapy, and may change the radiotherapist's approach as far as the dose of radiation therapy delivery, although it's, in talking to our radiation oncologists, a relatively minor criterion, and does not predict outcome after radical prostatectomy, for example, may influence whether the surgeon decides to do nerve-sparing surgery on one side or not. But it's easy to report, so it's optional but recommended for reporting. So just to clarify, here is high-grade prostatic intraepithelial neoplasia, or PIN, and one should definitely report it if you see it in isolated form without cancer. But there's really no reason to report it if it's in the same core with cancer. It doesn't change clinical management. So if you see it in isolated form without cancer, in that core or that container. And if you see it in a case without any cancer, one should definitely make that diagnosis. And also note the number of cores that are involved. And this is a nice paper from Dr. Shrigley's group, just published in the Journal of Urology, highlighting the fact that there's increased risk when you have more than one core positive for high-grade pin. And here are just the different patterns of growth of high-grade pin. This is the tufted or mound-like pattern. This is the micropapillary pattern here. The tips have been severed and basically the plane of section, smaller nuclei at the tips, the cribriform or sieve-like pattern, and the flat-like pattern. You can see their patterns are often admixed, tufted and micropapillary being most common. And you can see here a tufted pattern admixed with a flat pattern high-grade pin. And this is the nuclear atypia you need basically for a diagnosis of high-grade pin. And it is a neoplastic proliferation within pre-existing ducts and acini. And we know that because basal cells, as we see here on the lower right, are still present within this gland. So, okay to report, optional if you like, but not absolutely necessary when it's in the same core as, or in a container diagnosis where there are cores with cancer. I do have to say though that if it's in a separate container without cancer, I'll go ahead and report it even if there is cancer elsewhere. So once you see high-grade pin shown here, along with admixed cancer, it's really not necessary to report it. So moving on to TURPs and enucleation specimens, what are the required elements? And here they are, and we'll march through these in order: procedure, specimen size, histologic, and just like for needle cores, same histologic typing, same approach to histologic grading. Quantitation is similar, and we'll talk about that, and this is really uncommon in TURP chips and enucleation specimens to see local invasion into fat or seminal vesicle. So this is simple, just the type of procedure, TUR or enucleation, again meaning simple or open prostatectomy. So we do touch upon tissue submission and recommended amount of tissue to submit in the CIP protocol. And for TURP chips, we recommend submitting, when you have 12 grams or less, all of that tissue. And if you have more than 12 grams, submit the initial 12 and then one cassette for each additional 5. You can try to pick out chips that might be more suspicious for cancer, but really that's really a futile exercise. And then what if we see cancer that's incidental and unsuspected, clinically unsuspected, in the initial round of examination of slides? We haven't submitted all the tissue. Well, probably one ought to go back then and submit the remaining tissue if you do see cancer that's pretty focal, less than 5% of chip tissue, because that's an important clinical staging cutoff. Less than 5% of TURP chip tissue or enucleation tissue involved versus greater than, because it'll change the stage from T1A, clinical T1A, to clinical T1B. So it's also straightforward that for these types of specimens, we provide the weight of the specimen, and for enucleation specimens, the size and 3 dimensions. Now here's where Gleason grading intersects with hormonal therapy, because we can see TURP chips where the patient has a previous diagnosis of adenocarcinoma, treated with hormonal therapy, and then develops obstruction, and a palliative resection or channel TURP is performed by our clinical colleagues. And so one should not apply the Gleason grading system when we see the classical hormonal therapy effects on cancer, as we can detect here in the image on the right. And basically this is nuclear pycnosis and cytoplasmic vacuolization. It can represent then a very challenging diagnosis and an insidious type of carcinoma to detect under the light microscope. And this the words on the left basically say this: don't grade after hormonal therapy, because this could have been a pattern 3 that now looks like a Gleason pattern 5. Another problem as well in detection is that these cancer cells, after androgen deprivation therapy, begin to look like lymphocytes or histiocytes. So one thing I do want to mention about hormonal therapy is that this does not apply to 5-alpha reductase inhibitors like Proscar and dutasteride. So it's felt that in general, the histological effects of those particular agents is weak to absent. So it's still okay to grade post-therapy, and if you consider 5-alpha reductase inhibitors as a form of hormonal therapy, if you're sure it was Proscar or dutasteride, it's okay to grade after those therapies. And again, radiation therapy, grade based upon whether there's effect or not. So for, as we were saying, for TERPs and CHIPs and for nucleation specimens, one should provide definitely a percentage, simple visual inspection percentage of tissue involved by cancer. And here's where that's because that impacts very strongly the clinical stage. Note that there is no pathologic stage T1 for the prostate, and T1A and T1B are strictly clinical stages, but based upon pathologic criteria. So here you can see that for clinical stage T1A, the cancer is incidentally detected in TERP chips or nucleation specimens involving less than 5% of tissue by simple visual inspection of all the slides and with no high-grade disease, meaning no patterns 4 and 5, and greater than 5% or any high-grade disease bumps the patient into a clinical T1B category. And it makes a difference because many physicians, urologists will consider active surveillance or watchful waiting with patients who have clinical T1A disease versus T1B. And it's also optional, but I do report this, the number of positive chips of the total number of chips identified under the microscope as another measure of amount of cancer. So same thing for nucleation specimens, a percentage of tumor involved. And you can also provide, on an optional basis, that's what the asterisks indicate throughout this session. That's optional. You can provide, if there's a single dominant nodule, the greatest dimension just by measuring using a ruler under your microscope, because we're not going to see it grossly or very rarely. So what are the non-required elements? Well, again, lymphovascular space invasion or perineural invasion, although I'd recommend reporting them when you do see them. What's not necessary to report in the presence of cancer: high-grade PIN, atypical adenomatous hyperplasia or adenosis, BPH and inflammation, although that's optional and you can report them if you like. But it's not going to impact. The point is that these parameters are not going to impact patient management. So moving along to our last major category, in the last part of our session, here are the required elements for reporting for radical prostatectomies. And the list is much longer, so we're going to be spending a little bit more time on this. Procedure is very straightforward, radical prostatectomy. You can also state what type of radical prostatectomy in this era, whether it's open or laparoscopic or robotic-assisted, for example. And then the weight is important, as is the provision of the size in 3 dimensions. Now, as to tissue sampling for radical prostatectomies, one can either completely embed, submit all the tissue into paraffin blocks, or you can partially embed. And if you partially embed, you probably ought to choose a protocol that's been well validated in the literature and probably cite that protocol too. So one that we mentioned in the CAP protocol that we particularly like for partial embedding is to submit a posterior aspect of each transverse slice along with a mid-anterior section from each side. And this is a protocol from Johns Hopkins, and it detects almost all of the foci that are important of extraprostatic extension and positive margins. And then for the margin submission, the ISUP recommendation and the CAP recommendations are to submit the entire apical and bladder neck margins as cones, although in the past many laboratories and pathologists submitted these as shave margins. But the conization method is preferred currently, and then a junction of each seminal vesicle with the prostate, showing that soft tissue base where cancer may invade outside the prostate into soft tissue and then into the seminal vesicle wall from without. It's not necessary to completely embed all the seminal vesicle tissue, but this particular section is quite important. Now, Gleason grading differs from needle biopsy in TUR cases when there's a tertiary grade. And what we do is basically not incorporate it into the score. There are some efforts to try to figure out a way to do that, but right now what you do is if you see a 3 plus 4 plus 5, you go ahead and give a standard score of 7 and then say that there's a tertiary pattern 5. So you just report it out without incorporating that tertiary high-grade pattern. And it does make a difference. Tertiary high-grade patterns in needle core, in radical prostatectomy, make a difference. Here's a paper from AJSP, Gleason score 7. What happens to those patients with Gleason score 7 if there's a small amount, less than 5%, of tertiary pattern 5? Well, you can see that these patients do have a more aggressive outcome than Gleason score 7 alone. How about quantitating the amount of cancer in radical prostatectomy tissues? You have a couple different ways you can do this. One way that we like is just a simple visual inspection, percentage estimate, just as we do in needle cores and TURP chips, of the amount of prostate tissue involved by cancer, and again in increments of less than 5%, 5%, 10, 20, 30%, so on, which is actually pretty simple and doesn't take much time. Alternatively, if you can identify a dominant nodule, and it's not always possible to do so, you can provide a tumor size in the greatest dimension of that nodule in millimeters and 2 dimensions if you so desire. So here's some data supporting the utilization of the percentage cancer, the percentage of the prostatic tissue that's involved by carcinoma, in the relationship of that number with outcome after surgery. These are data from Duke, published in Journal of Urology. And you can see with long-term follow-up how the increasing percentage of cancer adversely affects the likelihood that the patient will be free from PSA failure, that is, a biochemical failure after surgery. So here's less than 5%. Patients do pretty well, but once you've got greater than 50% gland involvement, patients do more poorly. And this was actually significant in multivariate analysis and was significant irrespective of stage. So it was still significant in the presence of someone with vesical invasion and for patients with organ-confined disease. And generally it was agreed, just going back to this quantitation, it was agreed in the ISUB meeting that one should definitely provide a figure, a number, when you're giving the patient and the physician idea amount of cancer in the prostate gland. So this is preferred over giving just a qualitative, subjective idea in terms of, well, there's a moderate amount of cancer or focal cancer. So in general, a number is preferred. Another required element is obviously extraprostatic extension, EPE. And so not identified versus present, and if present, one should specify whether it's focal or non-focal. And one should, even though in the CAP protocol we note that the reporting of site is optional, it is strongly recommended. So what are some of the challenges in diagnosing EPE? Well, first of all, the prostatic capsule is actually a fibromuscular sling that is incomplete anteriorly and apically. And it can be difficult sometimes to recognize EPE in these particular sites, posteriorly, posterolaterally, and laterally, when the tumor elicits a desmoplastic response. So we have a pushing type of tumor rather than obvious infiltration of individual glands into the fat. One caveat is that rarely you can see fat cells within the prostate, but just by convention, if you see cancer in fat, that generally means it's outside the gland. Anteriorly can be tough because in the anterior fibromuscular stroma often lacks glands that can serve as a reference for where the boundary is between the prostate and periprostatic soft tissue. At the apex, it can be particularly difficult because the edge of the prostate is ill-defined, and as we'll see at the urinary bladder neck, the prostatic stroma, smooth muscle, actually is in direct continuity with bladder smooth muscle. So here's an example of the so-called normal prostatic capsule. Benign prostatic gland here, periprostatic adipose tissue here, and somewhere in here is the capsule, but you can see that the smooth muscle bundles are basically merge and are in direct continuity. But if you see cancer, so if you see cancer out in the soft tissue that's in the same plane as the fat, then one should consider that extraprostatic extension, or obviously if it's in the fat. The problem can be drawing that line. So how do you draw a line sometimes when there's disruption and distortion of the tissue? That can be tough. Here is a section of the junction of the urinary bladder neck and the prostate. Benign prostatic glands here, thick, smooth muscle bundles of the bladder neck right here, and you can see that, well, it's, again, a continuity between those types of stroma. And you can see, well, if you wanted to draw the boundary, the line would probably be along here between intraprostatic versus extra. So let's now show some examples of extraprostatic extension. And you can see here PT3A disease, masses of prostate cancer out into soft tissue. That's straightforward, glands invading into adipose tissue. So the consensus is that you can diagnose EP in the absence of fat involvement if you can draw that line and show that the glands are in the same plane as the fat. And you can, using the same approach, identify prostate cancer anteriorly. And this is something that's in the protocol, that if you see cancer in skeletal muscle but without adjacent benign glands, go ahead and sign PT2. It's really tough to diagnose extraprostatic extension at the apex, where skeletal muscle can interdigitate into the substance of the prostate glands. So here are some examples of this bulging or pushing type of invasion into soft tissue, big bulging prostate cancer nodule out, clearly outside the prostate in the same plane as the fat. This is tougher, but generally, here is a bulging prostate cancer that is pretty much at the outer limit here within the same plane, so you could say that that is outside, and PT3A disease. Here's a nice image courtesy of Andy Evans, and again showing the line, the out here, a dotted line showing the outer aspect of the prostate, and at higher power you can see here the fat cells. And here is protrusion, a bulge of cancer cells outside, and so this represents then cancer that's gone into the fat. So here's an example of the anterior fibromuscular stroma of the prostate, and you can see we lose our glands for reference. So if you wanted to draw this smooth outer edge, it becomes difficult because you draw it along the outer edge of the prostate glands, and then you have to draw it out here into the anterior aspect of the prostate. There's the urethra for reference purposes. But it's still possible, and you can still diagnose disease if you're certain that it's beyond this imaginary curved line of the outer boundary of normal prostatic glands. Here's cancer, adenocarcinoma within skeletal muscle at the apex, and again, the edge is really difficult to identify here, so particularly in one distal apical section, I would basically assign a PT2 disease there. It's really tough to say that that is definitely outside the prostate at that site. So again, just to summarize, how do we report EPE? Report based upon the extent and location. Focal versus nonfocal, a term that's been used for nonfocal in the past, is established. How do we define focal? It's basically qualitatively just a few glands outside the prostate or tumor involving less than one high power field in one or two sections. And then nonfocal is greater than that. And location should be definitely specified. Here are some examples of focal versus nonfocal or established PT3A, extraprostatic extension, a few glands of adenocarcinoma wrapping around nerves, in the same plane as the fat, focal EPE, established extraprostatic extension, cancer growing along the nerves, extending out in the adipose tissue, clearly more than just a few glands, nonfocal or established EPE. And here are the data supporting this division. So you can see here on the left is the focal versus nonfocal using the qualitative few glands versus not, PSA failure after surgery, focal versus nonfocal. Here's PSA failure after surgery using the more quantitative high power field sort of approach by Tom Wheeler's group, focal versus nonfocal. So you can see it does make a difference irrespective of the method you use, and one has the freedom to choose to use either one of those two methods. But one of the two is definitely recommended. Now here's a big change for the TNM in 2010. It used to be that when we saw cancer in our radical prostatectomy specimens invading into the thick smooth muscle bundles of the urinary bladder neck, that was PT4 disease. It is now PT3A, and outcome data clearly substantiate this change in the staging system. And in fact, PT4 disease usually refers to cancers that are not surgically resectable. So seminal vesicle invasion is another required element. It's pretty straightforward, not identified or present, or if it's a unusual surgery, you may not get seminal vesicle. It's important that the diagnosis of seminal vesicle invasion be confined to those cases where the smooth muscle wall is invaded by the cancer. There are actually several different modes of extension, pathways of extension. You can get direct extension from soft tissue, shown here, tracking along the ejaculatory duct, shown here, or even lymphovascular space invasion, shown here in red. It turns out that the type of pathway does not influence outcomes, so need not be reported. But here are some examples of those pathways: direct extension into the wall of the seminal vesicle mucosa here, seminal vesicle mucosa, lymphovascular space invasion by carcinoma in the wall of the seminal vesicle. And then margins. So optional would be reporting benign glands at the surgical margin and whether the cancer is unifocal or multifocal. But actually, in citing the location, as shown here, you'll basically be stating whether the cancer is unifocal or multifocal and whether the margins are involved or not. So margins involved, yes, no, and if involved, then it's important to report the sites that are involved. So again, report location extent. And something that is new is that in the CAP protocol and at the ISUB meeting, the recommendation has been made to report the amount of margin involvement as linear millimeters. So this is relatively new, and I think we'll be seeing some data coming out as to whether this is going to stand the test of time. But for now, it's a way to quantitate in numerical terms the amount of cancer at the margin. Another important point is that margin status is separate from stage except in one circumstance, and that's when there's incision into the gland. So let's talk about that now. Because you can have a positive margin in the absence what we call PT2+, and that's not in the new TNM scheme, or presence PT3 with definitive EPE. So what are the definitions of a positive margin? Ink on tumor cells in our cones or at the periphery, as shown here. That's a clear-cut positive margin. And for when shaves are used, although shaves, again, are not recommended, carcinoma anywhere in that shaved tissue. So ink directly on tumor cells. It makes a big difference. So here are data out of Baylor showing the consequence of a positive failure. This is failure after surgery, progression-free probability over time, long-term follow-up out to over between 10 and 15 years, failure with a positive margin compared to a negative margin. And using a meta-analysis, it basically imparts a 3.7, almost four-fold increased risk of progression after surgery. Now, one needn't worry about close approach or measure close approach because it's been definitely shown that just even a few fibroblasts, if you're certain that there are fibroblasts, if there are a few fibroblasts separating the cancer from the ink, then it's okay to just call it negative. Don't need to worry. Outcome will be like a negative margin. So here's an illustration that John and I have in the CAP protocol for capsular incision. And it's not addressed in the 2010 AJCC TNM scheme, but I would use this term PT2+. If there's been clear-cut incision into the prostate with ink basically on benign glands, immediately adjacent to ink on carcinomatous glands. And we call it PT2+ because we really can't tell whether it was a PT2 or PT3 at the time of surgery. All we can see is that it's PT2+ in our histologic sections. Getting towards the end of our last category here of radical prostatectomy treatment effect. If you see it, go ahead and report it. Again, the big impact is don't grade if there's hormonal therapy effect, or if there's radiotherapy effect, don't provide a Gleason grade. I think in the future we may start seeing other therapy effects such as chemotherapy, which is now being used for some high-risk patients in a neoadjuvant setting, failures post-cryotherapy, and other therapies as they emerge. So lymphovascular space invasion, it is a required element. Go ahead and report it if you see it. It does impact outcome in almost all series in an independent manner. So here are 3 big series that reported on the prognostic impact of lymphovascular space invasion, shown here: benign prostatic glands, lymphovascular space invasion by cancer, basically conforming to the shape of the lymphatic channel. So go ahead and report that if you see it. So let's talk about the changes in TNM in the last few minutes. So the big change is that microscopic bladder neck invasion is now PT3A, not PT4. Gleason score is now the preferred grading system. And now the stage groupings are actually a combined anatomic prognostic grouping that includes Gleason score, pre-op serum PSA, and TNM. So here is the 2010 AJCC UICC staging scheme, basically the same as the 2002 scheme, except that microscopic invasion of bladder neck is PT3A. Also in the CAP protocol, there's been a lot of debate about subcategories of PT2A, B, and C, so we have an asterisk next to those different sub-stages because it really doesn't provide any prognostic impact as far as patient after surgery. So it's been on the chopping block for some time, these PT2 substages. And the big question is whether they would even be included in the new 2010 AJCC TNM. The answer is yes, it is. But you can see in published data that outcome is very similar for these patients who have PT2A versus PT2B, for example. And it really doesn't make a difference for outcome. So you can go ahead and report it. I still do report it, but recognize that it's just not going to have much of an impact on the patient, and one needn't agonize and spend a large amount of time trying to judge whether it's PT2A versus B versus C. So PT4 disease, as we talked about earlier, is really usually bulky disease that invades the rectum, or as shown here, urinary bladder, big nodules of prostate cancer invading into the bladder. And those patients usually are not surgical candidates such that we won't see them at radical prostatectomy. Regional lymph nodes, the big change is that one should go ahead and measure the diameter of the largest lymph node metastatic deposit, in addition to providing the standard present absent lymph node mets and the number of examined nodes and the total number of nodes involved by cancer. And it's pretty easy, really, shouldn't take much time at all. Here's a metastatic deposit of prostatic adenocarcinoma in the lymph node, and you can just again, slap a ruler on here and measure the greatest dimension and provide that in one's report. Really pretty easy. Shouldn't take much time. Distant mets, as far as metastasis, the big change is that, first of all, that it's very often not applicable, that we don't know what the exact stage is. And so for that reason, PM0 is not used in the 2010 TNM as it was used in 2006. If you know of the patient having definite distant metastasis, you can go ahead and report that. So here are the new groupings, the anatomic stage prognostic groupings, as published in the new 7th edition Cancer Staging Manual for Prostate Cancer. And as you can see, it's got our classical TNM stages that we assign, and our clinicians help us assign, especially for the M part. But now there's also PSA level as well as the Gleason score, highlighting how important it is that we assign Gleason score in our radicals. So this is not something that we necessarily need to report, and we don't have that in the CAP protocol, but we need to provide the information that is the T and N data and M data when applicable, and the Gleason scoring so that our clinical colleagues can fill out this new grouping that is published in the AJCC TNN. What's not required and what doesn't make a difference for outcome and for patient treatment: perineural invasion, high-grade 10 inflammation, adenosis, nodular hyperplasia, molecular testing. So none of this is standard. Actually, I do report these in our Synovic, but it's optional. You can report them if you see them and if you like, but it's not, again, going to influence therapy. Perineural invasion, unlike in the needle core, it's a bit different in that it's very common, found in almost 9 out of 10 cases, and it really doesn't impact outcome. And that's been validated very recently in a paper published in Modern Pathology in 2008. So you can report it but recognize it's not going to change outcome or therapy. What will change outcome and therapy and what is used for enrollment into clinical trials, all of these parameters. So this is a post-operative Caton nomogram predicting patient outcome up to 10 years after surgery, predicting biochemical recurrence. What's important from our standpoint: margins, yes, no; extraprostatic extension, yes, no; seminal vesicle invasion, yes, no; lymph node positivity, yes, no; and the Gleason score. And in the end, we all work very hard on our prostate cancer reporting, and this is where we can and we do have such a huge impact on patients' lives, and this is what we want to stop. And with that, I would like to thank you all for your attention and your stamina, and apologize for the technical glitches at the beginning, and I'd particularly like to thank Dr. John Shrigley for the invitation to present this session, as well as the Canadian Partnership Against Cancer, Canadian Associated Pathologists, the CAP, and the CAP Cancer Committee GU group, and co-authors on the CAP prostate protocol. And with that, the slide presentation session has concluded, and I believe we'll take questions at this time.
Peter, thank you very much for that very clear presentation. We do have a number of questions that have come in already, and I'm sure we'll be rolling in a little bit more as we speak. The first question that we have is from Dr. Corey Wegensberg of Scarborough, which is an area of Toronto. Why Gleason score per container or core? Why not per patient? Is the question.
Right. So the question is, why not provide a score for the patient? You know, this is something that we've debated, and actually we had included in the 2006 CAP protocol, that is providing a composite score. I think that's probably what you might be referring to at the end of the report. So since that time, it has become clear what the urologists and what our clinical colleagues do is that they will take the container or core with the highest score and use that for patient treatment. And so that's why we have shifted our emphasis away from a composite score for the whole case to score by container or individual positive core.
Okay, the second question is from Dr. Alexander in Brampton, Ontario. What is the clinical significance of ASAP versus high-grade TIN in needle biopsies of prostate? So the question is, what does it mean as far as patient management? A diagnosis of, here we're talking about isolated, that is pure form ASAP, atypical small acinar proliferation, or atypia, versus high-grade TIN. And actually there is a difference. And it's generally acknowledged that for ASAP, that this patient is at significant risk for subsequent detection of cancer in the next rebiopsy session at 3 to 6 months after the initial biopsy session when we diagnose ASAP. And that risk is generally in meta-analyses about 40 to 45%. So 40 to 45% of patients will be diagnosed with carcinoma on subsequent rebiopsy after we diagnose ASAP in the initial biopsy. That figure actually goes up a little bit when the atypical glands are right next door to high-grade TIN. High-grade TIN, on the other hand, should still be considered a risk factor, although what has happened over time
is that it's probably not as strong a risk factor as it used to be. And some series are now coming out that it's not a risk factor for subsequent detection of cancer. The data are still a bit mixed on that, and so the general recommendation is that one should still go ahead and report isolated high-grade prostatic intraepithelial neoplasia or high-grade PIN in cases when you do see it. And what's important, as highlighted by Dr. Shrigley's work and Dr. Epstein's work, is that one should report the number of cores positive, because that seems actually to have now a much bigger impact on the risk for subsequent detection of cancer. So report both. Recognize ASAP is a bit stronger as far as predicting cancer on the next round of biopsies.
Okay, our next question is from Dr. Sebastian Labonte, Laval University in Quebec. If fresh tissue is harvested for research, do you put a note in the report stating the possibility that there's limited evaluation of margins and extraprostatic extension?
So that's a really good question. What to do about cases where tissue is harvested for research? So we do this pretty routinely in all of our radicals that we see, and we do specifically have that in our report, mainly as part of an intraoperative consult. The tissue was taken for tissue banking. We actually have not added a comment saying that it might impact stage or grade, stage or margin assignment, and if one is really careful, I think one can try to avoid issues with that. And if you incise into the gland and try to take tissue from inside without disrupting too much the capsule, I think it is possible still to not compromise stage and margin assessment. On the other hand, I've seen cases where big wedges were taken, and those wedges included a lot of extraprostatic tissue and a substantial amount of margin. In those cases, you might want to consider it. But on a standard basis, we don't currently do that if we're confident that we haven't disrupted to a great degree that the outer contour of the prostate.
Okay, the next question is from Dr. Melody, McMaster University, and the question is as follows. What are management options when assigning Gleason 7, 3+4 versus 4+3?
So management options for patients with Gleason 7. So really everything is still under consideration. So usually men with high-grade disease are not considered candidates for active surveillance, although in the published series there are some men who have high-grade disease, and probably those are older men with competing health problems. So while not recommended, a few men have been enrolled in active surveillance. So then it becomes a question of radiotherapy versus radical prostatectomy, and really the difference is going to be, that decision is a difficult one because there are no prospective randomized controlled clinical trials directly comparing the two, and it's often a decision the patient will make along with the physician. There are nomograms that can predict response to radiotherapy, and they incorporate Gleason grade as well. So that predominance of 4 does make a difference when patients and physicians go to those nomograms. So, and it's true for both radiotherapy and radical prostatectomy that they'll see an impact of the 4 being primary rather than secondary, an impact on predicted outcomes. So that may influence the counseling of those patients. And urologists want to know too. I mean, is it a bad 7 or a good 7? Basically, they want to know.
Right. Second question from Dr. Melody is: do we report high-grade PIN on TERP specimens?
So the question is, high-grade PIN on TERP specimens as far as diagnosis? Absolutely yes, I would. It is a risk factor for subsequent detection of cancer, and interestingly, high-grade PIN can occur in the transition zone, although it's usually found in the peripheral zone. And the available data do indicate that it's a risk factor, so that patient ought to undergo biopsy of the peripheral zone.
Okay, next question is from Dr. Paul Neal, And it's as follows. Does Gleason score guide whether additional tissue would be submitted for a TUR specimen after the initial 12-gram sampling?
So can Gleason score influence things? It can, although our recommendations in the CAP protocol relate mainly to cancer amount, that is, if it's less than 5%. So the Gleason score impacts things, obviously, even if it's less than 5%, if there's high-grade disease pattern 4 or 5, the patient automatically becomes then a clinical stage T1B. So, yeah, the score can make an impact if you see high-grade disease up front, even for the small cancers.
I'm wondering whether he's talking about the grade determining whether or not all the tissue is put through after your initial 12-gram sampling.
Oh, right. So that's what I was trying to address, not very well. So if you see a small amount of cancer, less than 5%, and it's high-grade disease, then you've already established that the patient has clinical T1B disease. So then you need not put any more through. But right. if it's low-grade disease, then less than 5%, then probably ought to go ahead and do that.
Okay, the next question is from Dr. Karen Sklees. I can't pronounce the name very well, from Guelph. What if 2 to 3 foci of EPE? Do you still call it focal or established?
So using the Baylor approach, so it depends on whether it's a high-powered 40x field or not. So that defines the foci, and if it's on 2 separate slides, 2 separate foci, still less than one high-power field, it still can be focal. But if you go beyond that, then it becomes non-focal.
Okay. Question from Dr. Brenda Brooks, Cambridge Memorial Hospital. For positive margins, posterolateral or lateral, do we have to specify whether left or right side?
So left versus right, I do in my reporting. I don't know that we did that in the CAP protocol, but I write it. So it's an optional sort of thing, but I do provide left versus right.
Okay.
PT3A doesn't make a difference, by the way, unilateral versus bilateral.
Question from Dr. Leanne Wijanarko at Sudbury Regional. What do we mean with total linear measurement in needle biopsy? Is it per core or total cores?
So basically the linear measurements that I provide are based upon the container. So I will sum basically the total length of linear millimeters of cores or core fragments in a single container and report that out as total linear millimeters for that container.
Okay.
The challenge can be what constitutes tumor stroma between individual foci. For example, if you've got a needle core and you've got cancer foci at either tip, is that whole core involved, or do you just sum the small little foci? For the moment, we've been summing the small little foci, although right now there are very little data as to how much interval space you should incorporate or not in deciding what's an individual focus. Anyway, sometimes it's clear, and you can just then give the different linear millimeter lengths and sum them.
Okay, our next question is from Dr. Adrian Gulligan, Jewish General Hospital, Montreal. In your practice, how often do you report Gleason grades 1 and 2 for biopsy cases and for prostatectomies?
Yeah, that's a great question. So Gleason grade 1 and 2 in needle biopsy has basically gone away, and it's been recommended formally by the ISUP that we rarely, if ever, diagnose Gleason score 2 through 4 in needle core tissue. In fact, I can't remember the last time that I did, and when I did, I was invariably wrong in that there was usually higher grade disease in the entire radical specimen. So, in very rare cases, I might diagnose a Gleason score of 5, but 5s and 6s don't make much, are not much different. So the bottom line there is don't diagnose Gleason score 2 through 4. That's for needle biopsy. Now, for radical prostatectomy, there is no question that scores 2 through 4 exist, but usually because the needle cores are directed toward the peripheral zone where the higher grade disease resides, meaning patterns 3, 4, and 5, the radical is going to be done for that higher grade disease. So, in general, when you see these transition zone cancers, they really don't impact the patient's outcome, and it's the peripheral zone cancers that are going to, a higher grade disease that's going to have the big impact. The lower grade disease has really been diagnosed in the past and still can be as an incidental finding in turf chips, and that's where you're going to see most commonly Gleason scores 4 and 5. I've actually never diagnosed a Gleason score of 2, a 1 + 1 = 2.
Okay, we have another question from Dr. Alan Wolfson in Ottawa. It's regarding needle biopsies. Every core needs reporting, period. So should checklist requirements be repeated for each positive core? This becomes unwieldy if, for example, 6 or 8 cores are positive.
So I agree with you completely, and John and I agree with you based on our discussions from the past. So I was transmitting the fact that some urologic pathologists still report that way, but we prefer to report by container. So that way, you can get specific grade and extent per container, rather than having a core, let's say a container with 5 or 6 cores, and you have 5 or 6 cores positive. I agree that can be unwieldy. We've still left open that option though of reporting by positive core because that's the practice of some, but we recommend by container.
Question from Dr. Raymond Mong. 1 core biopsies, if there are 2 small foci each away from each other, how do you measure the size of the tumor? From one to the other, or the two foci separately? I guess so 2 foci at either end of a core, say.
Right. So that's what I was trying to discuss just a few minutes ago. And right now, we just don't have data to help us decide what the approach is. Right now, using that example of a needle core with 2 small foci at either end, I sum the small little foci rather than taking the whole core as being positive. Right now, you have the freedom to do either one because we just don't know which one works best.
Okay, we have a question from Dr. Richard Casper, Kelowna General Hospital. The clinical question is, serum PSA a good screen for prostate cancer, and would you recommend it uniformly?
That one's opening Pandora's box there. So, as everyone knows, serum PSA screening has been controversial, and there were 2 large prospective randomized clinical trials just published in the New England Journal of Medicine raising questions about it. One, the U.S. big screening trial, CLICO, was actually negative. Screening did not have an impact on mortality, whereas the European screening trial showed a 20% reduction in screening, but a lot of men had to be screened to achieve that reduction in mortality. So a PSA is controversial, and as far as its use in screening and early detection, some medical groups, societies recommend offering the patient a serum PSA test when they reach 50, and maybe if you're in your 40s, if you have a family history and are African American or have of African descent. And so that's been recommended by some societies, but not by others. The double-edged sword of screening is that we're detecting, while there's a reduction, at least in the European trial, of mortality, we're detecting very many tiny cancers that are not going to impact the man during the course of their life. And so here's where we can have a big impact in selecting men for surveillance. So based upon our accurate Gleason grading and quantitating amount of cancer. Clearly, we need a better screening tool. PSA has real problems in specificity. Most men with an elevated serum PSA actually have a benign reason for that elevation being BPH or inflammation as the basis for that elevation. So there are real problems. I think the story is not completely out yet because those results from the European screening trial and the U.S. screening trial are actually at intermediate endpoints. So at 7 to 10 years. So at 15 years, I think we'll have a better idea, but PSA has definite problems, and we need a better PSA. And the final thing I'll say about that, this is a bit long-winded, but what we need is a PSA for high-grade disease. We need a serum marker that will correlate with our Gleason Gleason score 7 through 10, and then we can be detecting those cancers that are most likely to harm the patient.
Okay, the next question is more administrative. It's from Dr. Dunn, Noria, and others in Scarborough that just say, can you send us an evaluation sheet? And Dunn, yes. Andrea will send it out to your office once we're finished this call. The next question is from Dr. Sylvia Dancia, Sudbury Regional Cancer Program. Do you report the largest single dimension of foci of carcinoma on core biopsy?
So I don't report the largest single dimension, but the sum of the total. So if there's just one big focus, I'll report that as linear millimeters. If there are multiple foci, then I'll report the millimeters as total length.
Okay. A follow-up question from Dr. Alan Wolfson in Ottawa, getting at that previous questions regarding the multiple checklists. If multiple specimen containers are positive, should checklists be repeated endlessly, or how do you use checklists for multiple positive containers?
Yeah, so I'm going to ask for John's consultation on this one. And I think when we're reporting, we're basically reporting by container, and you can have different grades and quantitation for each container.
Yeah, I think when that question has come up a number of times with the checklist, and what we've said in I think it's in the current one as well, is that the report per container or per core, if it's a single core in a container, can be just a simple line item stating the adenocarcinoma, the Gleason score, primary, secondary, number of cores involved, then your extent measurement, just as a string, as a line string, which is in a sense a synoptic, a checklist type report. So as opposed to having a long tabular list in regards to each of the specimens. But certainly that is an issue, and it's going to come up in the Ontario project as well when we start to implement the checklist for prostate cancer biopsies, positive biopsies.
Right.
And I think that is all the questions, Peter. So I'll just make a few closing remarks. On behalf of the Canadian Partnership Against Cancer and the National Staging Initiative and the Canadian Association of Pathologists, I really like to thank you, Peter, for a truly comprehensive, informative, and a very, very clear presentation today. Once again, I apologize for the technical glitches in getting the audio working at the beginning of the conference, and we'll sort of look into that with WebEx and see what the problem is. This is our second teleconference in our series of CAP checklist presentations, and I'm sure that there are some procedural lessons to be learned, and we would welcome your comments and suggestions. If you could please send them to the following email address, pathology@partnershipagainstcancer.ca. As some of you know, the Canadian Association of Pathologists is actively working to sign a memorandum of understanding with the College of American Pathologists that would see additional Canadian input into the checklist via both the CAP Cancer Committee and also a CAP protocol review panel. So we're looking forward to a greater working collaboration between the Canadian groups and the College of American Pathologists. As a reminder, both the live and the recorded presentations are eligible for continuing education credits. The evaluation form for the presentation was previously distributed. Please return it electronically completed forms to pathology@partnershipagainstcancer.ca in order to claim your educational credits. Once the WebEx recording of this presentation becomes available, it will be made available widely through the distribution list, through the Partnership's National Pathology Staging Committee, and also the Canadian Association of Pathologists, and as well the local provincial members of that standards committee will make it available through their local, regional, or provincial associations as well, such as the Ontario Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. Finally, I'd like to thank the members of the Partnership National Pathology Standards Committee for their valuable time and assistance in putting this event together. Our next presentations are scheduled as follows. On February the 22nd at 1 o'clock Eastern Standard Time, Dr. Susan Lester is going to give us an overview of the new CAP checklist for breast cancer. And on February the 23rd, once again at 1 o'clock Eastern Standard Time, Dr. Kay Washington is going to give an overview of the new CAP checklist for colorectal cancer. And we look forward to seeing you then. Once again, I thank you for your attendance, and I bring this teleconference to closure.